All right. Assalamu alaikum, everybody. Uh, I think we have about enough participants to start the interactive session. So I hope everybody can hear me clearly. I assume there are no issues in hearing me. So if they're not, just let me know and I'll start the session. All right. Okay. So we have some participants of the previous course as well. Unfortunately, I wasn't able to hold an interpretation session with them due to their exam commitments. So now I'm holding a joint session of both the first and second groups of extraoral radiographs. So just for their revision and your revision as well, I'll briefly go through the interpretation of different X-rays that I've already covered with you guys, just to refresh your memory, and then we'll get into the cases. All right. So before that, one thing I hadn't taught you guys was how to describe a pathology that you see on an X-ray, specifically an OPG, because that is predominantly what you will be ordering for a mandibular lesion specifically. And this is what is sometimes usually held as an OSCE station or a TOC station in your IMM and your FCPS Part 2 exam. So whenever you are describing a lesion radiographically, this is the checklist that you should go through. And I'll just briefly go through this with you guys. In the beginning, we'll be having a few trauma slides in which I'll be expecting you guys to diagnose where the fracture is. And in the end, we'll have some slides related to pathology. So I hope you will apply this checklist on that to the best of your ability. And inshallah, once today's course is over, you'll take this pattern and wherever you are training or working, you will apply that pattern over there. So for at least for exam purposes, one station of yours hopefully will be covered adequately. All right. So starting from the radiological description of a lesion, the first thing that you have to do is start with the site or the anatomical position of the lesion. For those of you who I taught OPG recently, I gave you a checklist where you had to go through the entire OPG. But recently it has come to my attention that especially in the IMM talks, that you're not given enough time to report on the whole OPG. In fact, some of the examiners will stress that you just report specifically on the pathology. Okay, so I won't be going through the entire checklist about how to describe an OPG, nor would I be expecting you to do that. You can do that for academic purposes in your ward discussions, but for exam purposes, it's probably better that you stick to just describing the pathology. So you just start directly with the pathology. You have to start with which site or which anatomical position you are looking at the pathology, plus its probable epicenter, like where it is arising from. All right. The lesion might be extending from, let's suppose, from the ramus till the body, but its epicenter would be its central portion. All right. So you should be reporting that this pathology has probably arisen from the mandibular angle region and has now spread to the ramus and the body region of the mandible. Okay. Other than that, you should report roughly its size in centimeters or in boundaries. But like I have told you guys before, there is about 25 to 30% magnification in an OPG. So it's probably better you don't comment on it in centimeters, because you'll have to adjust it for magnification. So it's probably better you just report on what the boundaries of the lesion are, and that can give you an approximate idea of its size. Okay. So other than site and size, then you have to talk about the shape of the pathology. Is it unilocular? Is it multilocular? Is it pseudolocular? Is it round, oval, scalloped, undulating, irregular? All right, you just basically describe its shape. Then you have to focus on its outline, its edge, or its periphery. Is it well defined? Is it poorly defined? How is it? All right. Even if it is well defined, is the boundary more radiopaque? Is it less radiopaque? All right. So you have to comment a bit about its boundaries. Then you have to focus on what is the relative radiodensity of the pathology that you are seeing. Is it radiolucent? Is it radiopaque? Is it a mixture of both? And what is its internal structure? Do you see some trabeculae in it? Are there multiple septae? Is there any calcification in it? Or is it uniformly radiolucent? Okay, so you have to comment on that. Then what we are interested in hearing from you guys is what is the effect of this pathology on the surrounding structures? Okay, so if it's if some teeth are involved, then please do comment on whether you see tooth resorption, or are these teeth displaced? Are these teeth impacted? Is there a loss of the lamina dura? Is there increased pedial space? Do you see any hypercementosis? What about the effect on the bone? Are you seeing any expansion, displacement, destruction, new bone formation? What is the status of the ID canal or the mental foramen? And if possible, comment on if you see any extension of the pathology into the soft tissue. Okay. And although in this checklist, I've written the time in the end, you should ideally always comment about when this OPG was taken along with its the patient biodata at the very beginning of the description of the X-ray. All right. Okay, coming to the PA views of the mandible, I'll obviously be talking here about the PA mandible and the reverse towns. So in that, whenever you have to describe the lesion, you have to start the outline from the condyle on one side to the other, and you have to comment on the lower border in between. So what do you have to note? You have to note any alteration in the shape outline, any step deformities, specific areas where you should be noting where fractures are most common is the angle, the condylar necks, the body, canine region, ramus, and the coronoid process. So in these areas, what do you have to look for? You have to look for any radiolucent fracture lines, the direction of the fracture line, the degree of separation of the overlying of the bone fragments, and any radiopaque lines which may indicate overlapping of the fracture ends. Now, this was the OPG interpretation sequence, but like I told you before, you are probably not going to be given enough time to report on the whole OPG. And if you do start, but I would still advise you to start reporting on the whole OPG. If the examiner tells you to focus specifically on the pathology, then that's a separate thing. But if they're looking for the completeness of your OPG report, then you should follow this interpretation sequence. But again, like I said, probably since you have maybe 5 minutes in every short case and 5 minutes in your TOEICs or OSCEs, so probably it's wise not to use all of that time reporting on the whole OPG and just try to focus on the pathology. Okay. So this is the interpretation sequence of that. Again, I won't go through it. I've just already described this too last week to the new candidates of this course. Now coming to the OM views, in this I had told you guys about the Campbell lines. So you have the line 1, you basically have 5 lines, but 4 lines were originally introduced by Campbell. The 5th line, which follows the inferior border of the mandible, that was introduced by Trapnell. And you have some secondary curvatures, and these secondary curves were introduced by Dolan and Jacobi. So we'll just go through what these lines are and what structures do you have to report on when you are discussing these lines. So line one passes through the right FZ suture, through the right supraorbital ridge, through the frontal sinus, and on through the same structures on the left side. In line 2, you have to start from the zygomatic arch, then the body of the zygoma, right infraorbital region, nasal complex, and the same structures on the left side. Line 3 starts from the condylar neck through the coronoid process to the lateral wall of the right antrum or the zygomatico-maxillary buttress, then the base of the nasal complex, and the same structures on the left side. Line 4 basically passes through the angle of the mandible into the occlusal plane and the angle on the opposite side. And line 5, which was introduced by Trapnell, just follows the inferior border of the mandible. So these are the Dolan and Jacobi's lines. So these are basically 4 lines, only 3 are given in here. 4th line is basically the lateral outline of the nasal cavity. That is Dolan line 4, but unfortunately I couldn't find a single picture in which all 4 lines were given together. However, in this picture, you can see line 4 is given over here. All right, if you just follow my cursor. So in these line 3, you can start from anywhere you want, but if you remember it sort of counterclockwise, then it's easier to remember. So you start from 3, which is the lateral wall of the antrum, as well as the inferior border of the zygomatico-temporal suture. Line 2 is the superior border of the zygomatico-temporal suture, as well as the outer border of the FZ. And line 1 is the orbital line, all right? And line 4 over here is the orbital. So 4, 3, 2, 1. So you're basically going counterclockwise, all right? So if you remember it sort of counterclockwise, it will be easier for you to remember. All right, so let's come to the cases. So we have, I'll just go number by number on the participants that I have. So we have Dr. Asfia with us, number 1. So Dr. Asfia, are you with us?
Assalamu alaikum.
Wa alaikum salam. All right, Dr. Asfia, please comment on this X-ray.
Okay, I try. I just joined the session.
No,
okay?
Everybody's learning, so it's just practice.
All right.
Start whenever you're ready.
There is a radiolucent line on the left side of mandible.
All right. What else do you see?
There is extrusion on teeth on the left side lower first incisor.
Okay, would you say this is extrusion, or would you say this is a displacement of the fracture?
Yes, I think this is displacement. There's whole dentoalveolar fracture. So the teeth involved.
Or do you not think that this fracture line is communicating at the inferior border of the mandible?
Yes, it's also going.
Yes, so then it won't be a dentoalveolar fracture, right? Dentoalveolar means to the alveolus, and it's not communicating to the inferior border of the mandible. But here you can see this step deformity over here. So if you're able to see that, it means it's not a dentoalveolar fracture. So it's a through and through mandibular fracture.
Okay.
What else do you see?
There are grossly carious teeth.
All right.
On left side, lower third molar is grossly carious.
All right.
Upper upper right 6 and 8 are also grossly carious.
Okay.
Are there any other findings which I'm missing?
Yes, that's why I'm asking.
Okay.
What else do you see?
They are missing teeth. 7 and 8 are missing on right side, lower right side. 7 and 8 are missing.
Right, fine. how about we go a bit, systematically, so that way you won't
Mhm.
things, because we have quite a few findings in this case. So
Mhm.
there is one method that I taught you guys in the previous session, which was regarding a complete reporting of the OPG. I also told you guys
Mhm.
that it's not necessary that you follow this method. You can follow whatever method you guys like, but it should be comprehensive and cover everything. Okay, so the method that our teachers used to teach us during our residency was that you basically start from the condyle on the right side, condyle and coronoid on the right side, and then you go through the ramus, then the angle, body, PS, symphysis, and then the same structures on this side. All right. Then you come to the maxilla, look at the maxillary bone over here. If you see any findings, well and good. If not, then you can come to the teeth. All right. So if you had followed this method, you would probably have noted that there is a doubling of the condylar head. If you can look very carefully, you can see one outline that I'm drawing over here and another outline that I'm drawing over here.
Yes.
So whenever you see a doubling of the condyle, that is always a sign that there is probably a condyle fracture over here. Okay, so you have a condyle
Okay.
fracture over here in the right condyle. All right. Then if you compare this condyle over here, so you can only see one single line, so it means this one is intact. The coronoid processes bilaterally appear to be normal. The rami on both sides appear to be normal. The angle regions on both sides appear to be normal, as well as the body and the PS side on the right side appears to be normal. However, in the PS region on the left side, there appears to be a step deformity at the inferior border, which is passing upwards obliquely, and it's ending approximately near the apices of the opposite central incisor or the same side central incisor. All right. So I'm not very sure where the fracture line is ending over here, but since the step deformity is between the central incisor and the lateral incisor on the right side, even though the fracture is starting from the left side, so I would probably assume that the fracture line is has involved the apices of the central incisors in the mandible. All right. So
All right.
you can comment on this radiolucent line, which is extending upwards till the superior cortex of the mandible and appears to be involving the maybe apices of the central incisors on both sides. Okay. So with this
Okay.
completely on the mandible, then I'll come to the maxilla. Now, on the maxilla, I can't appreciate any significant findings in the bone. The maxillary sinuses on both sides appear to be somewhat radiolucent, although this is not the best X-ray to comment on the status of the maxillary sinuses. The nasal cavity is not very clear in this OPG, so I can't give any comments regarding that. Coming to the maxillary teeth, I can appreciate that on the left side, there appears to be a missing upper third molar. There appears to be some distal caries in the second molar, and there appears to be a restoration in the maxillary first molar. There's probably a missing second premolar on this side, as well as I cannot appreciate a crown, or there might be a retained root over here. Again, the X-ray is not very clear, so I cannot make any clear conclusions. Then come to the anterior area. So from the canine to the canine area, I cannot appreciate any pathologies, and in this involved sextant, and probably these teeth all appear to be fine. Coming to the right side, I see that the upper right six has lost its crown, and there just appears to be maybe some broken down roots, which are possibly associated with some periapical radiolucency. All right. The second molar appears to be intact. However, the upper right third molar, the crown of this tooth is showing an extensive radiolucency, which may be implying caries. However, periapically, this tooth appears to be normal. All right. Then I'll come to mandibular teeth. So in the mandibular teeth, you can start again from any side you like. You can start from the right side. So you can say that there appears to be a restoration in the crown of the lower right six. Other teeth on this side appear to be normal. However, there appears to be a step deformity between possibly the central incisor on both sides, which is probably due to the fracture that I can see at the inferior border. The other anterior teeth in this area appear to be normal. There appears to be restorations in the lower left 6 as well as 7. However, beneath the restoration, I can appreciate a radiolucency affecting the crown of the lower second molar. In addition to this, the crown of the lower left 8 is also showing an extensive radiolucency, which again could be implying caries. And there appears to be bone loss in the bifurcation area, as well as some periapical widening of the PDL in this area. There appears to be loss of the lamina dura over here. All right, so this is how I would report on this OPG X-ray. So as you can see, it took me a long time to report on the whole OPG. So it depends on the examiner if they will tell you whether they just want you to focus on the fracture or not. All right. It's very probable that once you had diagnosed this fracture and this fracture over here, they would stop you over right at that time. They would ask you to come up with your diagnosis and then how you would like to manage this case. But they probably won't ask you to explain the whole OPG. All right. So next.
All right. Thank you.
I have to describe the whole OPG, try to describe it in this way so you won't miss anything. All right. Shannon. Let's move on to the next case. All right, let's see who we have next. We have Dr. Ali. Dr. Ali, are you with us?
Yes, sir.
Please kindly comment on this OPG.
Sir, here this is an orthopentogram patient whose name is not mentioned on the X-ray, and not the age of the patient is not there. There's a from right condyle, it looks okay, and in the parasymphysis and symphysial area, there is some radiopacity look like in the
right side or on the left side.
And if we go on the so in the parasymphysis and symphysial area of the mandible of the right side of the patient.
All right. Okay. Okay.
And then if we move towards the left of the patient, there's missing molar teeth, and lower 6 lower first molar is missing probably. And if we go towards the left condyles, there's we can't find significant findings, and we can't see any in the coronoid area, and there's nothing look like. I don't know if something is there. And from the maxilla, left antrum is radiolucent, and two molars are missing. And if we move toward the right side, right antrum is look opaque, and right side molar is missing, and no, premolar is missing probably, and then second molar is with the caries.
All right.
And all I can see is I think this is I can appreciate over here, and if you can guide me.
Okay. Let's suppose I tell you that this is an OPG of a trauma patient. So would you need what would you comment on then? Do you need anything extra?
Sir, PA view, I can at right angle we need an X-ray of at right angle PA view.
Which
So,
view would you like?
Submento vertex.
Submento vertex. Why would you like a submento vertex view?
So to see the sinuses.
Sinuses, but you said you want a PA view. Vertex is
Yes,
not
sir.
a PA view. It's an OM view.
Yes, sir.
Which X-ray would you like?
X-ray. Best idea is go for the CT.
Go for the CT. Well, you are working at a periphery. You don't have access to a CT, so and you still need to be sure that there is no fracture over here or not. So, what would you like to call for?
Clinical plus radiographic findings. Clinically, we can see the patient clinically, and then.
Okay, but you don't have the patient right now, na? So if let's suppose you are, let's suppose you are doing this consultation via, you're doing an online consultation. Okay.
Yes, sir.
You can't see the patient, but your colleague who is working in the periphery has sent you this X-ray. So you're saying you're not sure there could be a fracture over here. Additional view would you like to ask for? देखें अगर ओपीजी ऑर्डर हुई है तो इट मींस के मैंडिबुलर फ्रैक्चर सस्पेक्टेड है सो जी सर वुड यू कॉल फॉर सर इसमें वैसे मैंडिबल फ्रैक्चर कहीं आई कांट द सिम्फिजियल एरिया में समथिंग इज एंगल एक्स्ट्रा रेडियो कैपेसिटी जो आपको यहाँ नजर आ रही है दिस इज बेसिकली सर्वाइकल स्पाइन का शैडो है ठीक है सो आर्टिफिशियल ठीक है तो इसको फिलहाल भूल जाएं टेल मी देयर इज स्टिल what other x-ray would you like to call would you like to advise
angle left angle might be fracture might be some lines are
what so again my question is what view would you like to ask for then do
sir PA view
which PA view can you specify that I want you to ask
PNS PNS
sorry
PNS
PNS is an occipitomental view you're asking for a PA view of the mandible so which PA view of the mandible would you ask for
आप गाइड करने में
अच्छा देखें आपके पास दो PA views इनफैक्ट 3 PA views होते हैं ठीक है PA skull होता है ठीक है PA skull is basically done just to give you a rough overview of the entire facial skeleton all right so you can either order a PA skull but it's not specific for any one side all right आप suspect कर रहे हो fracture of the left angle let's suppose ठीक है left angle का आप fracture suspect कर रहे हो then you can opt for two views one is the Townes view and one is PA mandible all right ठीक है तो इन दो views में से एक view आप order करोगे ठीक है तो the view is the reverse Townes view ठीक है इन areas के लिए कंडाई एंगल इन areas के लिए वो अच्छा view होता है ठीक है अगर आपके पास रिवर्स टाउन्स आपके जो एक्सरे टेक्नीशियन रिवर्स टाउन्स करना नहीं जानता तो प्रेडोमिनेटली आपको वो पीए मैंडिबल करके दे देगा ठीक है रिवर्स टाउन जो होती है वो ओपन माउथ में ली जाती है अक्सर फ्रैक्चर का पेशेंट जो होता है वो मुंह खोल नहीं सकता प्रॉपर्ली ताकि वो एक्सरे ऑलराइट तो वो पेशेंट एक्सरे टेक्नीशियन जो है वो आपको पीए मैंडिबल करके दे देगा ठीक है तो देन यू आर गोइंग टू ऑर्डर अ पीए मैंडिबल सो नाउ mandible has been ordered. आप बताएं
जी सर angle this is angle fracture and also the parasymphysial and parasymphysial
exactly ठीक है, लेकिन अगेन देखें मैंने आपको अभी पीए व्यूज रिपोर्ट करने का तरीका बताया था. यू हैव टू स्टार्ट फ्रॉम द कंडाइल ऑन वन साइड, फिर आप नीचे बॉर्डर को फॉलो करोगे जिस तरह मैं यहाँ कर्सर को फॉलो कर रहा हूँ, एंड दूसरे साइड के कंडाइल तक आप इसको लेके जाओगे. ठीक है, ये सारे एरियाज में आपने कोई स्टेप डिफॉर्मिटी या रिड्यूसेंट लाइंस पे कमेंट करना है, नंबर 1. दूसरा, आपने की एरियाज को देखना है जहां जहां फ्रैक्चर होता है, विच इज द रेमस, कंडाइल, केनाइन एरिया, एंगल. ठीक है, ये 4-5 एरियाज हैं जो अक्सर फ्रैक्चर होते हैं. ठीक है, तो एरियाज में आपको कमेंट करना है फॉर व्हाट, अगेन रिड्यूसेंट लाइन, डबलिंग अगर वहां आपको नजर आ रही है, स्टेप डिफॉर्मिटी आपको नजर आ रही है, एटसेट्रा. ठीक है, अभी अभी जो चेक आपको पढ़ा. ठीक है, so you are seeing 2 fractures over here. One, you can see a non-displaced fracture of the angle. कर्सर के साथ बना रहा हूँ, इसको फॉलो कीजिएगा. ठीक है, नंबर 1 ये हो गया. तो इट मींस इट्स नॉट डिस्प्लेस्ड, क्या कहते हैं, बकुलिंग इतना डिस्प्लेस नहीं है. ठीक है, लेकिन सिम्फिसिस एरिया में फ्रैक्चर है यहाँ. ठीक है, यू कैन सी अ स्टेप डिफॉर्मिटी ओवर हियर. तो जो डबलिंग आपको नजर आ रही थी वो इसलिए भी नजर आ रही थी क्योंकि यहाँ फ्रैक्चर लाइंस की समवट ओवरलैपिंग होती है. ठीक है, तो सर्वाइकल स्पाइन पे शैडो भी हो सकता था, लेकिन वो एक्चुअली एक फ्रैक्चर था की वजह से वो आपको डबल नजर आ रहा था. ठीक है, तो चलें, गुड. ऑलराइट, चलें अब आते हैं towards our next candidate. We only have about 3 minutes left when this meeting will end, so I'll just restart it and तब आप इस पे we'll continue it. अच्छा, so we have, I think, Dr. Sagba है हमारे पास. जी, Dr. Sagba, are you with us?
जी, अस्सलाम वालेकुम.
वालेकुम सलाम. Kindly comment on this X-ray, please.
जी, I can appreciate PA mandible.
Are you sure this is a PA mandible? अभी आपको फर्क बताया था between PA mandible and reverse towns. दोनों में क्या फर्क होता है?
Angulation का, I think.
एंगुलेशन का भी है. क्लिनिकली आपको कैसे पता लगेगा कि ये रिवर्स टाउन्स है या ये पीए मैंडिबल है?
Clinically कैसे पता चलेगा?
जी, as in when you look at the X-ray आपको कैसे पता लगेगा कि ये are you looking at a reverse towns or are you looking at a PA mandible?
थोड़ा सा ऊपर से लेते हैं, थोड़ा सा नीचे से लेते हैं, जो याद आ रहा है. I'm very sorry.
रिवर्स टाउन्स जो है वो ओपन माउथ लिया जाता है, तो you can see there's a gap between the upper and lower teeth.
This is
ये
an
आपको पिछले
all right,
X-ray में नहीं नजर आ रहा था. ठीक है, so this is basically a reverse towns
view of the mandible, in which I see that there's a radiolucent fracture line on the right side, which it's most probably a body fracture of the right side of the mandible. And I can also appreciate that there's a tooth in the fracture line, and I can also both the ramal areas seem to be symmetrical, as well as the orbits, and the chin area.
Orbits आपको नजर आ रहे हैं? Because this is, ये तो nasal cavity है, and this is the maxillary sinus. तो orbit तो यहाँ ऊपर कहीं,
but
Sorry?
not very. Everything seems to be symmetrical, but not very pronounced.
अच्छा, what else do you see?
At the chin region, there is mixed radiopaque radiolucency at the chin region.
ये again वो होगी because shadow है ना, तो it might be difficult to interpret this area.
जी.
अच्छा, so basically you have, would you call this a displaced fracture or a non-displaced fracture?
That I could for that to comment, I need another view at 90 degrees to check the orientation of the displacement. for to comment if it's a favorable one or a non-favorable one.
ठीक है. Right. So we don't have a lateral view